Okay, good morning, everyone. It's already mid-September, so welcome back to our University of Toronto Department of Ophthalmology and Vision Sciences Grand Rounds. We'll start off the academic year by welcoming back one of our own. So many of you may recognize Dr. Marko Popovic. He's a medical retina specialist who has recently been recruited back to the Department of Ophthalmology in the University of Toronto and has started clinical practice at both St. Michael's Hospital and the Kensington Eye Institute, as well as the Kensington Vision and Research Institute. Dr. Popovic completed his clinical fellowship at the Stein and Doheny Eye Institutes at UCLA, where he worked with international leaders in the field of retina. Prior to this, he completed his medical degree at the University of Toronto, and he also completed his ophthalmology residency with us at the University of Toronto, where he was one of our star residents and served as chief resident in his final year. Marko, thank you for making the time to present Grand Rounds this morning. I look forward to your cases, and for me as your past program director, it's an honor to watch your growth and welcome you back to the department. So I look forward to many years of collaboration, and I also want to welcome Dr. Michael Ballas and Dr. Heba Al-Khatin, our PGY2 and 3 residents who will be presenting cases this morning.
Thank you so much, Amandeep. I really, really appreciate the opportunity and the chance to deliver Grand Rounds. I mean, it's, I'm kind of pinching myself, having been in the seat so many times as a resident and watch other staff as they gave their Grand Rounds to now be, having a session myself. It really, really feels like a tremendous honor. So thank you for the opportunity. Thank you for the chance to do this. Heba and Michael are awesome, and they've prepared amazing, cases for us today, which I hope are very informative and of a lot of learning value. The thing I'll say before we get started is that many of these cases you won't see in many textbooks or, you won't see on your OCAP exam, so I think the residents can breathe a little bit easier because a lot of these cases are novel and some of these areas are very much emerging quite recently. And we're gaining much more understanding very recently in some of these entities. So I hope to shed some insights on what we do know about some of these kind of novel entities, which, I think are, despite being, recently characterized, are seen in clinics. And hopefully it is of some learning value. So with that said, I'll turn it over to Michael to get started with the first case, and we'll go from there.
Great. Thank you, Dr. Popovic and everyone else. Let me share my screen here. Okay, so good morning, everyone. Thank you for joining us at Grand Rounds. I'll be presenting a case that at first looks like a run-of-the-mill advanced macular degeneration, but ends up being something much more unusual. I've titled it Mystery Maculopathy because I want us to walk through the case together step by step and hold off on naming the diagnosis until we've looked at the imaging and thought through the differential. And so by the end, we'll uncover a condition that many of us might have heard of, many may not have, and but few have likely seen firsthand. Slides showing up okay? Okay.
Yeah, you're good.
All right, so our patient is a 74-year-old male who's been referred to us for follow-up of what was thought to be advanced AMD in both eyes. His best corrected vision was 20/40 in each eye, and his intraocular pressures were normal, as was the anterior segment exam. He's a new patient to our clinic. His past medical history is relatively clean, hyperlipidemia that's well controlled, no diabetes or cardiovascular disease. He's never smoked, and he has no history of any eye surgery or any kind of toxic exposures like Plaquenil or Almiron. So on paper, he looks like a fairly typical patient with dry AMD, but as we'll see, the images tell a bit more of a complicated story. So here we can see some ultra-wide field color fundus photographs of both eyes. These are in pseudo-color, and you can see that both eyes are showing some diffuse macular atrophy, but notice that it's sparing the center. There isn't any hemorrhage, but there is some reticular degeneration in the periphery, and already this feels slightly off for classic AMD. And these are just the true color fundus photos showing a similar kind of thing. Now that we're looking at the fundus autofluorescence, the right eye shows a speckled hyperautofluorescence in the macula with nasal hypoautofluorescence, and the left eye shows diffuse speckled hyperautofluorescence sparing the fovea with this early hypoautofluorescent atrophy. Again, it's multilobular, it's speckled, and not the neat round patches that we would typically expect in a GA.
Michael, I'll stop you there just to comment. What I'd like people to appreciate here, take a look at this left eye. I mean, if you look at this patch of GA, you see this vertical orientation, right? Where it's, extending beyond the boundaries of where you would expect a normal GA lesion to grow. So in a typical GA lesion from AMD, it grows in kind of a centrifugal pattern. It doesn't really have any predilection for, vertical orientation, but you see how vertical this line, this, patch of atrophy here is especially noted on the left eye. So that's just something to, keep in mind here. Keep on going, Michael.
And now we're looking at some enhanced depth imaging OCT. It gives us a bit more information. And so looking at the right eye, we see these diffuse basal laminar deposits and pseudodrusen, as well as a thin choroid. And looking at the left eye, again, we see these basal laminar deposits, pseudodrusen, and again, a thin choroid. There's also some retinal pigment epithelium and outer retinal atrophy nasally, and an intact foveal EZ layer and a grade 2 ERM that we see. And again, we can see this kind of vertical finding here. And now looking at the en-face OCTA, we again see the pseudodrusen and basal laminar deposits mapping out kind of diffusely. The choriocapillaris shows some dropout, and that's highlighting the vascular impairment that might be also underlying the progression of this disease. So let's briefly pause from the case to define and go through some of the terms and findings that I just highlighted. So let's start by anchoring what pseudodrusen actually are. Pseudodrusen are also called the reticular pseudodrusen or the subretinal drusenoid deposits, and they sit right above the RPE in the subretinal space. That's fundamentally different from soft drusen, which are below the RPE. On imaging, these subretinal drusenoid deposits create this reticular grid on fundus view on fundus view or color photograph, and this speckled appearance on autofluorescence or on OCT, and you'll see hyperreflective mounds above the RPE like you see here. And that's right at the photoreceptor RPE interface. Clinically, that subretinal location helps explain rod dysfunction and nyctalopia, and that distribution often tracks with where the atrophy extends.
I'll make a quick comment there. If you look back on the previous photo, if you look at the distribution in a typical AMD case of a, drusen versus reticular pseudodrusen or SDD, there's typically a trizonal distribution whereby in the central subfield you have confluent soft drusen followed by dot, SDD in the perifoveal zone, and then in the perifoveal zone, even more peripherally, you have ribbon SDD. And so that pattern of like this trizonal distribution between drusen and pseudodrusen has been replicated many times and is kind of classically seen with a typical AMD case. And so as we showed in our previous case here, the patient has extensive pseudodrusen. It's extending beyond those kind of typical boundaries where you would expect in an AMD patient, and it's associated with this long vertically elongated patch of atrophy.
And now let's talk about what these basal deposits really are. So we have basal laminar deposits, and these are internal to the RPE's basal lamina. And you can think of them as a thickened or a duplicated RPE basement membrane. Histologically, it's this basement membrane-like material, including collagen type 4, laminin, and heparin sulfate proteoglycan, and it often forms this continuous sheet. On OCT, this would translate into a diffuse sheet-like mid-reflective material beneath the RPE, creating the impression of a broad separation within the RPE and Bruch's complex, but without any discrete drusenoid mounds. Now, looking at basal linear deposits, these sit external to the RPE basal lamina, and they're located within the inner collagenous layer of Bruch's. And these are composed of these lipid-rich membranous debris. And clinically on OCT, they take this nodular form, and it's essentially, you can think of as soft drusen, the classic sub-RPE drusenoid mounds we associate with AMD. And these thin layer basal linear deposits can also look like a flat sub-RPE plaque. I have some diagrams here that can help really explain and highlight what I've just discussed. This is what these basal laminar deposits would kind of look like, as this kind of band or spacing between the Bruch's and the RPE. And these are these basal linear deposits, these kind of mounds that go between, and this purple line here is the basal laminar deposit, which we're seeing in this case. And finally, before we name the diagnosis, here's a simple mechanistic read of the vascular findings and what they set in motion. So in OCTA, the choriocapillaris lab shows these patchy flow deficits, and the deep capillary plexus demonstrates refraction that tracks within the lesion footprint. On the enhanced depth OCT, the choroid was thin, and the RPE-Brux complex looked thickened or split, like we saw earlier. On autofluorescence, we saw a speckled hyperautofluorescent border around a progressively hypoautofluorescent core, and this is consistent with an expanding atrophic area. A straightforward way to connect these is an outside-in sequence. Reduced choriocapillaris and deep capillary plexus perfusion leads to lower oxygen and nutrient delivery and less efficient waste clearance at the outer retina. The RPE becomes metabolically stressed, outer segment processing is impaired, and a material accumulates at the photoreceptor RPE interface, often as these subretinal deposits above the RPE. That environment preferentially affects the rod, so patients will notice night vision difficulties early on. Over time, sustained stress will result in RPE and outer retinal loss with enlarging atrophy. And on the fundus autofluorescence, that's the hyperautofluorescent ring at the active edge and the hypoautofluorescence in the atrophic core. So going through all of that, without further ado, based on what we've seen, we have a 74-year-old with diffuse vertically elongated atrophy, pseudodrusen everywhere, a thin choroid, it's foveal sparing. What's on your differential? Would you call this AMD and geographic atrophy? Could it be Stargardt's? Could it be a cone rod dystrophy? Central areolar choroidal dystrophy? Could it be this EMAP thing?
We'll give everybody a moment to think about this one.
All right, maybe we'll share the results there.
All right.
It's that EMAP thing.
Yes. So people are wondering about EMAP and what could this be EMAP? So go ahead, Michael. Why don't you tell us what we think?
Sure. So most of you are correct. It is EMAP. This condition was first described in Italy in 2009 and has since been recognized as this distinct clinical entity, not simply a variant of AMD. It tends to present in patients in their 50s or their 60s. They're often female with bilateral symmetric disease. Our patient is slightly older than the typical onset age, but the imaging features are pretty classic. And the defining elements that we spoke about are these vertically oriented lobular atrophy, widespread pseudodrusen, basal laminar deposits, and peripheral degeneration. One of the hallmarks of EMAP is the role of these basal laminar deposits that we talked about. So in the pre-EMAP stage, patients have this reticular pseudodrusen at the parafovea and the mid-periphery. Over time, these are replaced by a sub-RPE mid-reflective material, the laminar deposits, with this clear split between the RPE, basal lamina, and Brux membrane. This separation precedes atrophy and tends to start in the superior fovea, then involve the fovea, and then the inferior parafovea later. And interestingly, the inferior parafovea is often the last area to be affected. So EMAP signature is these basal laminar deposits that sheet under the RPE, whereas the AMD pathway is driven by these basal linear deposits with soft drusen as the nodular manifestation. So here we have another question. Which OCT feature is most characteristic of EMAP compared to AMD-related geographic atrophy? Is it subretinal drusenoid deposits? Is it complete RPE and outer retinal atrophy? Is it diffuse separation of the RPE from Brux membrane? And is it the presence of an epiretinal membrane?
You know, I think we have a mix-up with the
Yes. I think we actually don't have this question as a poll, but we'll give everyone a few seconds just to think about their answer here, and then we could share it in just a bit then, Michael.
Yeah. And you're all correct. It's so how do we distinguish EMAP from geographic atrophy, which can look very similar? Well, both are bilateral. Both can be fast progressing, but usually EMAP's a bit faster. They're lobular, they're pseudodrusen rich. They've got these grayish fundus autofluorescent borders. But EMAP usually presents about 20 years earlier in the 50s rather than the 70s. The atrophy tends to be vertically oriented, like we spoke about. And importantly, EMAP shows this peripheral involvement, whereas AMD is usually confined to the posterior pole. So when you see this geographic atrophy-like lesion in someone who's younger, it's got some vertical extension and these peripheral paving stone changes, it might be worth considering a diagnosis of EMAP. And so this is what I'm talking about in regards to the peripheral retinal involvement. It often cinches the diagnosis. The mid-periphery will show this like fading pseudodrusen replaced by this expanding paving stone-like degeneration. And over time, speckled hyperautofluorescence may evolve to this patchy atrophy. The periphery can show anything from subtle RPE changes to full pigmented chorioretinal scars. And these peripheral lesions tend to worsen and eventually merge with macular atrophy. So the disease is pretty diffuse, not just macular. On the figure on the right, we see this distribution of peripheral retina involvement in previous large case series of EMAP. And so findings of these pseudodrusen and paving stone degenerations typically occur infratemporally and least commonly supranasally in 6.5% of cases. And so this is just putting a picture to all of those words. They show examples of these kinds of peripheral retinal involvement. On the left there, the color fundus photographs in figure A. This is a patient with a predominantly central pattern showing RPE alterations in the peripheral retina. In B, it shows a patient with predominantly peripheral pattern, and they've got these 360 degrees of pigmented chorioretinal atrophy. And in C, we see the right eye of a patient with this paving stone-like degeneration, specifically in the inferotemporal sector where it's most common. On the ultra-wide field autofluorescence on the right there, we see in A this peripheral RPE change displaying a predominantly hyperautofluorescent signal, and then these pseudodrusen-like deposits exhibiting a heterogeneous autofluorescent signal. In B, we see these peripheral paving stone-like degeneration displaying hypoautofluorescence in the inferotemporal retina, and then it becomes indistinguishable in the supratemporal region. And then C shows a speckled hyperautofluorescent signal in the mid-periphery. And so these are the kind of findings that you would expect. Now, unfortunately, EMAP has a pretty poor prognosis. Up to 60% of patients will progress to long-term blindness. 1 in 4 will develop a large central scotoma, and another quarter show focal openings or even ruptures of Bruch's membrane. And this is a distinctive feature of EMAP that we don't typically see in AMD. Atrophy grows quite quickly, around 3.6 millimeters squared per year, and this is faster than geographic atrophy. And this aggressive progression means that early recognition and counseling are important for these patients. The figures on the right show these OCT scans of these hyperreflective pyramidal structures in Bruch's membrane ruptures that you can see with the white arrowhead markings over here. So final question, I don't think this is a poll question either, but which feature most strongly favors a diagnosis of EMAP over geographic atrophy? Presence of reticular pseudodrusen, bilateral and symmetric involvement, vertical orientation of macular atrophy with peripheral paving stone-like degeneration, and hyperautofluorescent borders. I think you all know the answer. The answer is C. So how do we manage it? For our patient, we continue the AREDS 2 vitamins, though it's not clear how much they're really going to help in EMAP specifically. Recommended a cardiology evaluation, including carotid Dopplers, rule out any vascular contributors, discuss the potential risks and benefits of GA therapies, although there's, evidence is obviously lacking, and set up follow-up in a year with fundus autofluorescence, with the plan to consider if these GA inhibitors, if it progresses towards the fovea. But as with AMD and geographic atrophy, low vision support and early counseling are important in these patients. So here are the most important take-home points. First, think about EMAP when you see GA that's vertically elongated, pseudodrusen-rich, and in a patient who is younger than you'd expect for AMD. Second, multimodal imaging is important. Look for basal laminar deposits on OCT and scan the periphery for any paving stone and RPE changes. Third, prognosis is aggressive. These patients lose vision faster than AMD and GA patients. And finally, management is supportive. We don't have any proven therapies yet, but early referral for low vision resources can likely make a big difference in their quality of life. Okay, thank you.
Perfect. Thank you so much, Michael. So, I mean, a quite interesting entity here. This is a very hot topic in the area of retina, and it's very much one of these debates of whether you're a lumper or a splitter, right? If you ask some people who are, leaders in our field, they'll say this is basically a variant of AMD, but it has characteristic features. The peripheral paving stone changes. These patients might have nyctalopia, they might have delayed dark adaptation, the vertical orientation of the atrophy, and these patients are quite young. Some of them can come in being 55, 60 years old. And so we think that there's enough there to call this, a distinct entity, which has been termed EMAP with all of these pseudodrusen as well, in the absence of any kind of classic confluent soft drusen. And so it's something to know about, something to be aware of. This was first described in France and Italy, and they published a large case series in that part of the world. And the thought at that point was, could this be genetically related? Could there be certain environmental exposures in that part of the world that predispose to this type of lesion? And more recently, are we finding that there's these cases exist everywhere? We're recently publishing on the first case series in the United States in multiple centers of this entity, showcasing that it's really not a phenomenon localized to just Europe. And so, in any case, I want to move on for the sake of time, but I just wanted to stop right here and ask if there were any questions or anything on this case.
Marco, are there any risk factors for this, like age, genetics? Well, age doesn't seem to be a risk factor because they're getting it younger. But what about genetics, smoking, cardiovascular disease? Any risk factors that?
Yeah, so this is all being explored right now. I mean, as you saw, we did do a cardiology workup and Dopplers and whatnot to look at underlying vascular features. I mean, I think that's being established right now as to whether there's a relationship there. Smoking is definitely a risk factor, but beyond that, more work needs to be done. When you look at these large case series of these patients with EMAP, they have many of them have had genetic testing done, and it does not show any other inherited retinal dystrophy or maculopathy that's related to a genetic cause related to this, because that would be one of the first things you would think about if someone's 55 years old with such prominent atrophy. Can they have potentially some type of inherited retinal disease? And that's very much not been the case in these EMAP cases.
Very, very cool. Great case, Michael. Thank you for sharing. I just have one thought, which is it's amazing how fast our field moves forward. I think one of the things that draws many of us to ophthalmology is the technology. And, sometimes you can say, are you a lump or a splitter, but really our diagnostics are getting better as well. And EMAP was certainly not a diagnosis that I had heard of when I was a resident. And neither was PAM. And now both of these are, in the lexicon. So I think stay tuned. Just as our technology continues to improve, we're going to see more and more of these types of pickups. There's a question here before we move on, Marco. Can the new treatments with light therapy for early dry AMD also help these patients?
It's a good question. I mean, photobiomodulation is I think the jury's still out in general, and in whether there's a role in dry AMD, and there's a lot of research being done right now. I think there needs to be more study and more rigorous evaluation to see, first of all, does it even have a good role in dry AMD? And then in the case of EMAP, I mean, these are obviously rare cases, so I haven't yet seen any use of the photobiomodulation devices in this setting specifically. So, I really can't comment on that.
Okay. And a question from Dr. Lichter, could alcohol be a contributing risk factor?
It's possible. I mean, all of these various ways of, alcohol, smoking, etc., contributing to oxidative stress, that all, has an implication on the health of the photoreceptors at the end of the day. But, do I have strong evidence to support specifically alcohol related to EMAP? I don't. So that's still something that needs to be explored.
Thank you. All right, Heba, floor is yours.
I think we'll go on to
I've got
Michael's second.
Oh, I'm sorry, Michael, the floor is yours still. I'm
I've
sorry.
got another small little bonus case. I think I also read during my literature search, I don't know how accurate this is, but pesticide exposure has been at least thought to be linked to this in some way. But I guess we'll have to wait and see.
Exactly. I mean, well, that was the initial thought, because when this first started in Europe, they thought, could there be certain environmental toxins, pesticides, whatnot, that could be, that are very commonly used in that part of the world that may not be used elsewhere, which is why they're having so many of these EMAP cases in a small area. But what we're actually finding is that these cases exist probably around the world, not just in Europe. And so this idea of like a toxic relationship is somewhat being disproven now.
Great. Okay, so let's move on to our second quick case. We've got a 73-year-old female. She's got this complicated medical history. She had a severe pneumonia requiring hospitalization, complicated by C. difficile and fecal transplant, Crohn's disease with an ileostomy on vedolizumab. She's got chronic bladder pain, managed for 15 years with an oral medication. She stopped about 2 years ago. She has no history of any prior eye surgeries. Her visual acuity is good. It's 20/40 in the right, 20/25 in the left. There's been the slow decline in the right eye over several years. The anterior segment is age appropriate. She has mild dry eye, earlier nuclear sclerotic cataracts, and posterior vitreous detachments. In the back, there's bilateral macular RPE modeling and these mid-peripheral pigmentary changes. There isn't any drusen to suggest a typical AMD, and there aren't any diabetic changes. These are the baseline ultra-wide field color fundus photographs of both eyes that were taken in 2019. And here you can see some subtle macular pigment changes in both eyes. Now this is in 2021, and this is in 2022. And you can start to see that these pigmentations start to become a bit more pronounced. And here in 2023, they continue to become a little bit more conspicuous. And then now in 2025, over 6 years, they kind of evolve from this subtle macular modeling to clearer paracentral atrophic patches, with the very center still spared. You also see these peripheral pigmentary changes becoming more obvious as well. But here's when the really obvious things start. Moving on to fundus autofluorescence, you see this speckled posterior pole with expanding and confluent hypoautofluorescence around the fovea and around this parapapillary halo. Both eyes have this central autofluorescent island explaining the maintained acuity. And I've included this red kind of bounding box line around these select areas of hypoautofluorescence, just so it's easier to track its change in growth over the years. So we see here, this is in 2022. And then this is in 2023. We start to see things grow a little bit. And now in 2025, you can see these red bounds become larger, the speckled salt pepper kind of pattern becoming more evident. And now switching over to enhanced depth OCT, we see these kind of patchy ellipsoid zone loss in the parafoveal annulus, outer retinal tubulations at atrophy margins, and these inner retinal subsidence. And with all that, though, the fovea still remains intact. You can see here I've highlighted some of the areas of these tubulations, highlighted the EZ, and you can see around the fovea it's still there, but there's these patchy areas of loss. And finally, we also see some mild flow voids in the choriocapillaris on OCTA, specifically under the areas of damage. So here, I think we may have a poll question. Based on the clinical information in the images, what is the most likely category of disease? Is it dry AMD with GA? Could it be hydroxychloroquine retinopathy, toxic maculopathy targeting the RPE and photoreceptors, or central areolar choroidal dystrophy? Okay.
All right, we'll
And-
give that
yep.
seconds and that there. Okay. Very
Okay,
good.
and the answer is C. Based on the pattern, this paracentral atrophy, foveal sparing, speckled fundus autofluorescence, the best choice is C. I think the distribution, yep, perfect. The distribution and autofluorescent density are atypical for AMD. There's no hydroxychloroquine exposure, and CACD usually has a different natural history and pedigree. So the underlying culprit is this pentosan polysulfate-associated maculopathy. She took about 400 milligrams per day for 15 years, which is a cumulative dose of 1.8 kilograms. So she's firmly placed in the high-risk range. The bilateral paracentral phenotype with speckled fundus autofluorescence and an annular ellipsoid zone loss pattern is a classic finding. So now that we've revealed the diagnosis, here's why the patients end up taking this medication. It's a sulfated polysaccharide that acts like this glycosaminoglycan analog, or a GAG. So in interstitial cystitis, the GAG layer basically covers the bladder lining that's thought to be compromised. It coats and helps restore that barrier so there's fewer irritants that affect the epithelium of the urinary tract. And so it's prescribed by urology for about 300 milligrams a day for 3 to 6 months and then see how they're doing. It's generally second line after conservative measures, and side effects that patients should be counseled on include GI upset, easy bruising because it's got some anticoagulant properties, hair thinning, and most relevant to us is a retinal risk. I'm sorry, the image isn't showing up properly. So anyone on pentosan should ideally receive a baseline and periodic eye exam with multimodal imaging. So going off of what we discussed, which feature best supports the pentosan maculopathy? Is it A, isolated intraretinal thinning, B, annular parafoveal EZ loss, C, drusen with sub-RPE drusenoid deposits, or D, the classic bullseye sign? And it's B, the annular EZ loss that we saw before. And so here's what we know about Pentosyn maculopathy. Since 2018, there have been multiple centers that have confirmed a dose-dependent maculopathy. Patients report reading difficulties and dark adaptation issues. Fundus autofluorescence is disproportionately striking versus the color, especially in the early phases of the disease. The OCT localizes the injury to the RPE photoreceptor complex, and OCTA often shows this choriocapillaris flow deficit. Some patients continue to progress even after stopping, so early detection and cessation are important for these patients. And so now that we've talked about those glycosaminoglycans as the bladder's surface barrier, keep that concept in mind for the retina. Because pentosyn, like I said, is a highly sulfated polysaccharide that behaves like the GAG mimic in the interphotoreceptor matrix. And that's right where the photoreceptors hand in their spent outer segments to the RPE. So the leading model is pretty simple. The mimicry in the interphotoreceptor matrix disrupts RPE photoreceptor crosstalk, especially outer receptor phagocytosis. So the RPE gets overloaded and stressed, and because the drug is strongly negatively charged, it also binds within RPE cells, upsets lysosomal function, and that matches what we see clinically. There are areas of hyperautofluorescence from the stressed RPE that eventually collapse into hypoautofluorescent atrophy. And on top of that, the OCTA often shows early choriocapillaris flow deficits beneath the lesions, so there's likely some ischemic stress component amplifying that injury. And so put together, you get this classic parafoveal annulus of damage, ellipsoid zone loss, outer retinal tubulations at the edges, and a central island that explains the preserved acuity. And because the RPE photoreceptor unit is destabilized, some progression can continue even after stopping the medication. So obviously the first step in management is eliminating the exposure, coordinating alternatives. We want to monitor them annually with FAF and OCT. If there's any CME or CNV, we want to treat it. Avoid smoking and protect ultraviolet radiation can also be helpful, as in other degenerative maculopathies. And finally, involving low vision services. So the final question, what's the most appropriate screening strategy? I think we've already spoken about it. We want a baseline exam soon after starting, and then annual screening by about 5 years or after 500 grams of cumulative exposure. A is too late. Color alone isn't enough because it'll miss the early disease, and obviously D is incorrect. So here are the major take-home points from this talk. If there is a bilateral, symmetric, paracentral disease with speckled fundus autofluorescence and annular ellipsoid zone loss, consider a toxic maculopathy. A careful medication history will help clinch the diagnosis. Early detection is important because progression can stop regardless of stopping the medication. And finally, rely on fundus autofluorescence and OCT for detection and follow-up regularly. And that's all I've got. Thank you.
Perfect. Thank you so much, Michael. That was an excellent job and another great case. So, pentosyn maculopathy, again, more recently recognized with the use of this medication in patients with interstitial cystitis. I think the key point here is really that FAF image. Michael, if you want to just show once again that FAF image that you showed previously, because in the early stages of this disease, on the clinical exam and color fundus photography, can be quite subtle, but this is quite striking, this classic speckled appearance of the FAF. And you'll see here, this specialist was followed by my fellowship preceptor, David Saraf, since the beginning of this follow-up here. And you could see as the lesion actually continues to expand over time, even though the patient has stopped the Elmeron, suggesting an irreversible and progressive maculopathy even after the cessation of the drug. And so, this drug is quite toxic. So, patients who have, cumulative use over 1,000 grams are, there's an over 50% chance of developing this irreversible maculopathy. So it's something as retina specialists that we do screen for regularly in patients with this type of appearance on their FAF, and something that needs to be a part of your medication history. And then I think Parnian has a comment here. I just wanted to point out that we surveyed our urology colleagues a few years ago on their management of patients with Elmeron. They said it's exceedingly rare now to prescribe this medication due to the serious adverse events related to the macula, and they do send patients for baseline and annual exams to optometrists, much like Plaquenil, if someone absolutely has to be on it for interstitial cystitis. They're switching most patients to other meds ideally. So yeah, that's absolutely true. I mean, that's been my experience as well, that as more appreciation of this has kind of grown over time, this literature has also entered into the urology literature, and urologists are much more aware of this entity, now than they had been previously. I mean, at UCLA, what we did was what, my preceptors did was they basically took everyone in the urology clinic who had a history of Almiron and did a screening from A to Z of all of these patients to see whether there was a maculopathy. And now, in our UCLA retina clinics, we have many of these patients with pentosan maculopathy, some who, were known to have, were affected by this visually, and others who really were asymptomatic and had very early stages of the disease. And so thank you, Parnian, for that helpful comment. The other thing I'll note is, one thing that's being explored now is the systemic implications of all of this, because we do know that pentosan affects other tissues in the body as well. And so we've seen many of these patients with characteristic pentosan maculopathy who also have other issues related to the colon and to the GI system, things like IBD, as well as colopathies and polyposis that's been associated with pentosan maculopathy. And the jury's still a little bit out as to whether that's a direct toxic effect from the pentosan itself, or whether it's related to the underlying condition, the interstitial cystitis, both of which can be risk factors for these various GI conditions. So Dr. Lloyd asked, is pentosan basically no longer used because of high rates of this maculopathy? And yeah, I think over time, if you look at the use of pentosan over time, it has gone down considerably. The thing I'll note is that interstitial cystitis from the urology side of things is a difficult condition to treat. And so, Almiron is one of the only FDA-approved treatments for this condition, and actually works very well for the condition itself. And so, it's a little bit one of these things where, although the use of the medication is going down over time, given its toxic effects, sometimes you're caught between a rock and a hard place, per my understanding from urologists. And so, if they use it very cautiously, and they're trying to get screening, when possible. And, we're on our side trying to, broaden the awareness of this association, so that not only ophthalmologists but urologists are aware of this, so that patients can be appropriately screened. All right, so just in the interest of time, I think we'll move on then to Heba's presentation. So go ahead, Heba, whenever you're ready. I think you're on mute there, Heba.
Hi, can you?
Yep, we can hear you now.
Hi, I'm Heba. I'm a PGY3. Thank you to Dr. Popovich for hosting these grand rounds. I'm excited to talk about our talk today, which is about a large retinal capillary aneurysm, which is a new entity recently described by our very own Dr. Popovich. So, just an introduction here. So we have different types of aneurysms in the eye. We have a macroaneurysm, which involves the arterioles. We have a microaneurysm, which involves the capillaries. And now this new entity, which is a large capillary aneurysm, which is kind of an oxymoron, but we'll talk about that. But first, to begin, what do you think this is? I'll just give the audience a quick chance to have a look at this photo. Depending on what I talked about today, do you think this is a microaneurysm, a macroaneurysm, a macro-microaneurysm, or a retinal, or a large retinal capillary aneurysm?
All right, give it a few more seconds. So end the poll here, share the results.
Oh, wow. So everyone thought it was LARCA, but it's actually two people got it right. It was a retinal macroaneurysm. You can see if you look closely in the photo that it's involving the arterioles. You can see the big sort of spot there involving the arteriole especially on the IVFA. So a retinal macroaneurysm is an acquired focal dilation of the retinal artery or the arteriole. This is important for the rest of our talk, the sizes. So 100 to 250 microns in diameter. And it usually, as I said, occurs in the first 3 orders of the bifurcations, usually supratemporal, which was in the previous picture as well. And it's, as you guys know, associated with hypertension. And you can see here in the fundus photo, you can see like a ring of exudation. And then in the middle, you can see this sort of very dilated artery. And then on the OCT, down here, you can see the exudation on the OCT map, but on the peripheral OCT cut of the actual aneurysm, you can see this sort of hyperreflective lumen, this very large hyperreflective lumen with a hypo sort of reflective center. And this is important because this is a basic sort of pattern on OCT of any aneurysm. But like I said, what's important and how to distinguish between them is whether or not they involve the artery and whether or not they involve the capillary versus artery and the size as well. So we'll talk about how to differentiate. But in the case of a macroaneurysm, it will involve an artery or an arteriole, and the size is obviously large, giving the name macroaneurysm. Over here, we have an example of a microaneurysm, which involves the capillaries, and it'll also, the size is quite small, as you can see here. All these hyperreflective dots on IVFA represent these microaneurysms. And they're very common, as you guys know, and as you guys see all the time in diabetic retinopathy. So it's just a repetition of what I said. A microaneurysm are outpouchings of the capillaries. They're hyperfluorescent on IVFA, as previously mentioned, and the size is typically less than 100. So if we have something more than 100, we think large. If we have something less than 100, we think small. If it's coming from a capillary, we think of a sort of microaneurysm. If it's coming from an artery, we think macro. And it is the earliest clinical manifestation of diabetic retinopathy, but it can also be found in other stuff too. So this is just multimodal imaging of a microaneurysm. Again, the OCT shows this hyperreflective lumen with a hyporeflective center. Sometimes the hyporeflectivity can vary, but in general, that hyperreflective sort of circle is what's characteristic on OCT. And then you can see, obviously, varying levels of leakage as well on the IVFA. Okay, so let's get into LARCA, which is a large retinal capillary aneurysm. So again, I said capillary is usually small, but large is in the name of this acronym. So it's very interesting. And it basically describes an aneurysm or an outpouching coming from a capillary, but it is large, meaning that it is more than 100 microns. So you would expect that something that large would come from an artery, an arteriole, but this was found to be from a capillary. So that's pretty interesting. And you can see that here on OCT. Again, that characteristic OCT finding, a hyperreflective lumen with a hyporeflective center. So again, I'm just repeating here. So it's from the capillary, it's more than 100 microns. It has that hyperreflective wall. Oh, sorry, hyperreflective wall with a hyperreflective lumen, which means like the inside part, the center. And it has obviously surrounding, because it's an aneurysm, it's leaking. So there's exudation, there's fluid around it, usually that classic succinate lipid exudation and it's usually, this is important to a key point in LARCA is that it's very resistant to anti-VEGF therapy, and it's more responsive to focal thermal laser. So that's really relevant now to be able to identify these types of cases. And they can be either isolated or, again, in the setting of diabetic retinopathy or vein occlusions. Again, this is just multimodal imaging. You can see here, I wanted to focus on the IVFA. You can see that sort of pinpoint leakage that we see in microaneurysms, but this is a much larger area of leakage. And then on D, the OCTA, if you focus on that area, you may be able to see that sort of outpouching coming from the capillary plexus. And then the en-face OCT with that OCT cut we described earlier, where we have that sort of hyperreflective wall. Sorry, I was saying lumen earlier, but I meant hyperreflective wall with the hyporeflective lumen. And then again, this is the same sort of picture we have, but I wanted to really highlight the effect of the focal laser because, as we said, they're very resistant to anti-VEGF. They don't really respond well to anti-VEGF. But you can see here all of the lipid and exudation and the thickening and the fluid they tend to resolve with focal thermal laser. Okay, so now that we know everything about LARCA, let's get into some cases and clinically apply our new OCT finding. So this is our case here. We have a patient with BRVO, and they've been followed for macular edema. And as you can see, they've received multiple injections, 20 Lucentis, 30 Eylea injections. And obviously, there have been some sessions of focal laser. So you can tell that this patient has had very, very resistant, so macular edema that's been resistant to therapy. Their vision is 20/30 and 20/60 in the left eye. And the BRVO would be in the left eye, which is the worst eye. So over here, we have our a pseudo color fundus photo. And if you focus on here where the BRVO was, you can see this area here next to the optic nerve. It's sort of temporal to it. You can see this exudation there. So that's very suspicious. Could there be some sort of aneurysm there that isn't treated? And could that be the cause for the macular edema that is very resistant to the treatment? So we took a closer look there, and you can see here on the true color as well, that sort of exudation, what's going on there. And so the IVFA actually shows that large sort of leakage point, and it is quite large. It's considerable size, more than a microaneurysm. So this could be possibly a large retinal capillary aneurysm. And again, the exudates will really give you a clue there. So when your clinical exam, just try to look for exudates, and then you'll try to find that pinpoint, either a micro or a macro aneurysm. Just try to look for in your exam like a red dot in the middle of your of that succinate ring, and you might be able to find an aneurysm. So over here, the OCT just really highlights how you have that, again, the hyperreflective wall with that hyperreflective lumen, and then lots of cystic macular edema, lots of exudation that, again, didn't really respond to injections, but as soon as the focal laser was applied, he had 2 sessions. And then especially the one in August of 2023 there, the retina flattened, and finally the edema was treated. And then the second case here was actually one I saw on call a couple of days ago, actually. So I've been working on this presentation, and I've been keeping my eye out for LARCA because I wanted to see it, and I ended up finding one. So this is a patient who came in for a different reason. They had sudden vision loss for 3 months in the left eye, and they came in through the emergency through their optometrist. But they've been a diabetic forever, and they've had no previous diabetic retinopathy screening. They had vitreous hemorrhage in the left eye, which was the eye I was focusing on. But I said to myself, well, let me take an OCT of the right eye and see what I can find. I ended up finding, again, this hyperreflective wall with a hyperreflective lumen. And it looks like a LARCA to me. So that was pretty interesting. But what I wanted to highlight in this case was, will you inject this patient? Well, I know that the edema is extrafoveal, so you wouldn't inject them anyway. But let's say that the edema was involving the fovea, the significant loss in vision, and the edema was worse than what you see here, and you did see large retinal capillary aneurysm, and you know that this OCT finding, they tend to be resistant to anti-VEGF. Would you inject this person and potentially subject them to endophthalmitis? In a monocular patient? Essentially, they are monocular. Even though they have a vitreous hemorrhage, they have a brisk APD on exam. So I assume that their visual potential in the other eye is poor. So the main point I wanted to highlight here is that it will absolutely guide management. Would you subject this patient to injections in a monocular patient when the risks at this point outweigh the benefits just from this OCT finding? It's something to take into consideration. Versus, considering focal thermal laser for this patient for a better outcome. So this brings me to my.
Thank you, Heba, for that. In terms of thinking about the treatment of these lesions, I agree. First of all, anti-VEGF can be tried. I mean, there's some in the retina community who say, they've had good experience with anti-VEGF and that in some cases it works. But these lesions, as Heba notes, can be very recalcitrant to ongoing anti-VEGF therapy, irrespective of which agent you choose. And so focal macular laser, if you need to go ahead with it, is something that can be done. But something like this, quite off to far from the central subfield, not really associated with CME in the
Yeah,
center there, can also be observed. These lesions also can be monitored over time. But really, if it starts to be, starts to lead to a lot of exudation, especially if it comes down to the foveal center, these are the treatment options and considerations to be thinking about.
absolutely agreed. Okay, so this brings me to my next poll question. What would you name this OCT finding? It's fine, no pressure. We called it a large retinal capillary aneurysm, but I want to get your thoughts as well, to see what you would call this. So again, it's kind of an oxymoron here, but being that it's from the capillary, but I just wanted to get the audience's thoughts on what they would call it personally. And if you have any other ideas as to what you would call this entity, please drop it in the chat.
So we'll end the poll there and I'll show the results. So a little bit of a split. I mean, different people would name it different ways. And it's interesting because in the retina community, this is very much what happened in terms of different people calling the same entity or a similar entity by very different names. And so that's what Heba will share with you all next.
Exactly. It leads perfectly to my sort of next point, where there was a lot of, again, differences into what we call this, because it is a little bit, when we say macroaneurysm, we think of something coming from an artery or an arterial, but this is again coming from the capillary. So it's very strange to call it any like sort of so people call it a macroaneurysm, but it's capillary, which is confusing because you already have retinal macroaneurysm, which is known to come from an arterial. So that's when it starts to get a little confusing. There was a lot of debate on what to call this OCT finding. But our very own Dr. Popovich had conducted a DOVS study to help kind of unify the term and to give it an official kind of term for this OCT finding. And so how the DOVS method works is you bring a panel of experts and you ask them again and again what you would call the findings. So we, or Dr. Popovich and his team conducted the study using multiple photos and a literature search of 3 databases, asked retinal specialists with the expertise, and then agreed on a term for this finding. And it was distributed into the International Retinal Imaging Society, and a consensus was defined as more than 70% of agreement among the participants. And so over 3,000 titles and abstracts were screened, and all of these different names were found based on these abstracts. So we have perifoveal exudative vascular anomalous complex, or PVAC, telangiectatic capillary, retinal capillary macroaneurysm, microaneurysm, significant actively leaking microaneurysm on OCT, and other terms. I personally think that a large retinal capillary aneurysm is the best out of all these, personally. So the results of the first one showed that the large retinal capillary aneurysm and retinal capillary macroaneurysm were the 2 top choices. So they conducted another second DOVS survey, which showed that large retinal capillary aneurysm sort of took the cake and won. So this OCT finding would best be defined by that term. So in conclusion, the appropriate use of ALARCA will facilitate clear and unambiguous communication amongst ophthalmologists, and even me as a resident, being able to have this term as this entity, this very clearly defined finding on OCT, helped me understand the treatment of this better, and it can help guide management, as we've discussed. There's still a little bit of debate, changing its name depending on the underlying cause. So people still say that, if it's idiopathic, you call it PVAC, and if it's related to diabetic retinopathy, we call it TELCAP as per the Survey of Ophthalmology per Fort et al. So again, there's still, I think amongst the retinal community, there's always going to be lots of abbreviations and lots of different names for things, but it's, I think Dr. Popovich, what he did in his work is tremendous. And yeah, it's great to have this entity now that we can look for and that can help guide management. So thank you so much. These are my references.
Perfect. Well, thank you so much, Heba, for an awesome presentation and an excellent job, very clearly explained in terms of this entity of LRCA. And so, to be honest with you, this is an area where there was a lot of conflict in the community. I mean, in the US, they were calling this retinal capillary macroaneurysm. In Europe, they were calling it PVAC or TELCAPS. And so there were many different terms for the same entity. What we did in this, as part of this Delphi survey, we gave, experts who basically had published in this area. We gave them 17 retinal cases and asked them what is the preferred term that you should use. And we found that the agreement amongst even this group of experts who knows a lot about this area was less than 50% on the vast majority of cases, signifying that, yes, all of these terms have been introduced, but no one is communicating in the same way. And so that, really does not facilitate for increased research and more knowledge on a common entity, having so many different names. So this Delphi survey was really there to try to unify the nomenclature related to this LRCA, which, as Heba mentioned, has very clear treatment implications. So I hope, this is useful to everyone. I hope you learn something and can take this back, because this is very common. If you go through enough OCTs, you will actually see this not infrequently. And it's good to know what it is, and it's good to know what to do about it when you see it. So thank you, Heba. I'll open the floor up then for any questions about this one or any other of the presentations.
Well, I don't see any more questions. I do want to thank both Heba and Michael for their presentations. Those are excellent this morning. You both have excellent poise when presenting. So, and kudos to Marco, Dr. Popovich, for guiding our residents through that. Marco, just for the sake of our audience, if there's patients that they want to refer to you, where are you seeing patients these days?
Yeah, so I've started both at St. Michael's Hospital in the Retina Clinic, as well as at Kensington in the clinic there as well. So I'm happy to see any consults or any patients, any diagnostic dilemmas you might have, and happy to help with anything you might need.
Okay, great. And I can attest to that. I've already leaned on Marco and his retinal expertise, so thank you for that. He's been a great addition to our clinic at Kensington and St. Michael's. So that's where he's practicing. For those of you who may be seeking to have another retinal colleague in the city. Thank you everyone for a great grand rounds, and we'll see you next week. Enjoy your weekend.
Thank you so much, everyone. Congrats,
Thank
Michael.
you.
Congrats, Heba.
Thank you.
Bye.